come back to that. Now, as I mentioned, this study is ongoing, and what they're going to do is give PrEP to everyone now. It's open. It's been open. Everyone will be followed. And there's really a lot of very good sub-studies that are being done from this study, including to learn more about different dosing options. Whilst I mentioned 95% of people in San Francisco were on drug, it was also fairly clear that from the drug levels that people were not necessarily taking the drug every day. Yet, despite that, a lot of people seem to have got protection, even if they missed a few doses here and there. This raises the spectre and the possibility of having different dosing levels, perhaps a number a week, all that sort of thing. So the follow-up arm will tease out those things. Now, this study caught a lot of people on the hop and created a lot of excitement, including in Australia. And there is a need, I think, for some really clear guidelines to be put out about the use of PrEP. As an interim measure, the US Department of Health has put out this interim guidance about the use of PrEP, which some of you may have read. It's on websites if you want to have a look at it. So this is an interim measure to guide people on the use of PrEP in the meantime, because there's no doubt that some people will be accessing it and some people will be providing it. Some doctors will be providing it, including in Australia. So this is a bit of interim guidance. Again, I think we'll get more information in the next couple of months. We'll get a more considered a guideline for the use of PrEP. Now, to use PrEP, the company has to get approval from the regulatory authorities, both in the US and here in Australia. And it's been publicly announced that Gilead plans to lodge an application to use Truvada, the combination I mentioned earlier, for PrEP. It's probably almost... Have you heard whether it's gone in, Philip?
Yeah.
I think it's...
Yes.
Yeah, thanks, yeah. There's a letter floating around from 25 US organisations calling for that application to be fast-tracked. There are others, one notable organisation opposing the application. That's fine, that's debate. Anyway, the FDA will probably make its decision by 2012, and this is going to be very big news when it happens. So I'm suggesting we do need to prepare ourselves for the release of the FDA's decision, which by chance now is likely to be favourable, and then the pressure will be on from people to make it available here. Again, therefore, we've got to think about how we can make it available responsibly and to the benefit of the individual and the community. So I did want to, I'm using this slide to remind myself about the fact that there have been a couple of disastrous failures of PrEP, particularly in the two last ones, FemPrep and Voice. And I guess the take-home message proposed by Bob Grant as to the reasons for this is that basically people in this study didn't take the drug. The supports were not good enough, and that was the main reason it is suggested as to why the study failed. With the FemPrep study, it was also complicated by the fact that the people who participated on that were only on one drug, and it's also, I think, clear that you need at least two to make PrEP effective. So the picture for PrEP is quite compelling in the very carefully conducted studies in North America, where the supports are in place, where there's community mobilisation and awareness, as opposed to perhaps countries in Africa, etc., where the supports were just not there and the study supports were not good enough. So I think it's a sobering lesson that pills are not just going to by themselves deliver the results we want. People have to be supported. Anyway, that's basically a summary of what I said. Okay, I now want to just move on to the test and treat approach in San Francisco. And again, I need to thank Mapali Dar for providing me with these slides, which summarise Department of Health policy in San Francisco and their test and treat strategy. So they've set themselves a vision, which is to end new HIV infections in San Francisco. And how are they going to do that? They're going to reduce HIV incidence by 50% by 2017. And they're also going to direct their resources at the populations which are at greatest risk for HIV, no surprise, MSM, IDU, and transsexuals. I do not understand why sex workers are not on that list, but they are. So basically the principles of San Francisco's new HIV strategy is to use the resources they have in a targeted and efficient way, to really scale up testing, to try and throw everything at the epidemic, not just treatment, but also condoms, syringe distribution, that sort of thing, to offer universal care and treatment to all people with HIV and at risk, something that is not always widely available in the US, to try and get community viral load down, and obviously to monitor and very carefully evaluate what they are doing over time. Now, anyone going to any San Francisco Department of Health clinic or turning up at the hospital, regardless of CD4 count, is going to be evaluated for the initiation of antiretroviral therapy. And if the evaluation is clear, then the decision will be made by the individual and the doctor to start treatment. So test and treat. I think it's an unfortunate phrase myself. I prefer OT, offer testing, offer treatment. I think that gets over the compulsory thing that people read into it, but you know, that's something for us to consider. They're quite happy with that. So this is a slide basically looking at the decline of viral load and the decline of new HIV infections over time. And if you look at the light green bar going down, you will see that since 2004, the annual number of new cases has been dropping from almost 900 or so a year down to, in 2009, dropped down to 490 odd, something like that. And the information, and I'm sure we'll see another slide on this, another presentation at Croy, that it's going down even further. And indeed, may even reach less than the levels we are getting here in New South Wales. So that's a pretty impressive decline in new infections. And without going into the bars too much, what they're about is declining levels of viral load amongst the positive population. Viral load, the more viral load, the greater the risk of other transmissions. So this is a very compelling slide. The other thing with going on treatment is to try and get the virus suppressed as quickly as possible. If you do that, again, you reduce the risk of transmitting to other people. Again, 2004 to 2008, you can see that the months from diagnosis to the start of heart has lessened quite dramatically by 2/3, and the number of months between being diagnosed, put on treatment and suppression, again, has more than halved. So that's impressive. And so these two slides really show that not only are people doing well from treatment, we're getting the viral load down and suppressing it more quickly. Again, that's an added boost to reducing the risk of transmission to other people. I have always believed there are very strong correlations between the gay community in San Francisco and here. I think the pattern of the epidemic was almost simultaneous, and basically I think we can draw a lot of comfort from the findings and the approach of the San Francisco doctors and public health officials, and we should really see this as a very good example of what can be achieved. So what's been some of the global reaction to these new advances and to these really pivotal study? Well, the 2011 UN Declaration was certainly informed by those studies. PEPFAR is a huge treatment provision program set up by President Bush that has provided millions of people with antiretroviral drugs. Now, they have an advisory committee which decides how those drugs will be allocated, and they are actively looking at offering treatment as a priority to all serodiscordant couples, irrespective of CD4 count, because they find the 052 study so compelling. The Centres for Disease Control, a number of African countries are also moving immediately to offer treatment to serodiscordant couples, irrespective of CD4 count, and I think that will continue. The Centres for Disease Control of the US is doing pilot studies of the test and treat approach in New York, in the Bronx, and in Washington DC, which has a very high rate of HIV. However, in terms of New York, this has been overtaken by a recent announcement by New York City that it is following San Francisco's lead and offering treatment, testing and treatment, test and treat, very actively pushing that in New York. There's a new US national strategy which came out, unfortunately, just a little bit before these new pivotal studies, but it's a really good document, very, very well done with ambitious targets and, what's more, money behind it, something we don't have much of behind our national strategy. However, linked to the national strategy, they do have a prevention plan which is much more recent, and it has very sensible and encouraging, ambitious targets and actions, and again money to try and galvanise the approaches to prevention. And President Obama, echoed by Hillary Clinton, have called for an AIDS-free generation to be actively pursued. This is now US policy, that they will strive for an AIDS-free generation. Never been there before, the only country to do it. So there's a lot of good things happening out of the US now after 20 years of pretty slow activity. So there's Hillary's statement. You can read all about it. So what does all this mean for our HIV response? This is my take on the state of the epidemic in Australia. I think we've been a bit complacent, we've been drifting along, and we've been in a comfort zone for a number of years. But in our defence, there haven't been a lot of new developments either. And it's easy to accuse people of that. We can make some legitimate excuses for what we've done over the last 7 or 8 years, but we can't anymore because we've got new science. I think we're all worried about infections having crept up to 1,000 every year. That's really unacceptable and a bit of an embarrassment, considering we're still touted everywhere as the world leaders in HIV. And we've seen some of the social research and epi-data which is showing some increases in risk-taking behaviour and some decreases in the rate of testing. So they're all worrying things. But also, let's think about the opportunities we've got here. We've got a great health system. We've got a great workforce. We've got really high standards of clinical care and access. We've got a world-leading research effort. We've got a generally supportive community environment, and I mean wider community. I mean, there is no doubt that attitudes towards marginalised communities have improved. They're not perfect, but they have improved over the last 20 years, and particularly accelerated after the last several years. We've got cohesive communities, and that has demonstrated itself over many challenges in HIV in Australia. And we've achieved, if not virtual elimination, very, very low rates of HIV amongst IDU, sex workers, and mother-to-child transmission. We've achieved that through being brave and keeping efforts going. We've also got a rate amongst Indigenous communities which is not higher than the rest of the population. Again, that's really fortunate, maybe a product of good luck rather than good management. I think